Hello, everyone. My name is Fabian Proft, and I would like to welcome you to our newest episode of the Virtual Congress highlights from GRAPPA, bringing you the highlights from the recent Rheumatological and Dermatological Conference directly to you. And today we will be speaking about the highlights that were presented recently in Chicago, where we were having the opportunity to experience the newest evidence and science around psoriatic disease and also other rheumatological topics from ACR. Today, again, we have brilliant young Grappians that are going to present the highlights from basic science, clinical topics, and treatment. And then we will have senior GRAPPA members joining us for discussion. But we also welcome you to put your questions into the chat and we will direct them to the speakers. And I'm more than happy that we also again have a PRP joining us today. As we want to give everyone time to join, we will just wait a couple of more minutes until we get started. Okay, so I will just start with the introduction. And as you are perfectly familiar with the program, usually I'm here together with my wonderful co-host, Lourdes Perez-Chada. But today she's not able, and we want to send her our warmest wishes. Lourdes, looking really forward to have you here with us the next time when we are doing the highlights from the AAD. And today we will be discussing the highlights that were presented at ACR 2025. It was a brilliant conference in Chicago. If you were not able to participate in person, don't worry, because we got you covered, and we'll have the brilliant young Grappians today that are guiding us through the highlights that were presented in Chicago. And here are our disclosures. Without any influence on the current selection of the topics, because we only have the opportunity and the highlight and the pleasure to guide through the program today. As said, we just start up with the short welcome and introduction. We then have Hannah Johnson from Scotland presenting the highlights on basic science. She was supervised by Dirk Ellevoud, and he will also hopefully join us for the question and answer following the first highlight session. Then Andre Ribeiro, our current Young GRAPPA chair from Brazil, will take over and guide you through the highlights presented on the treatment of psoriatic disease at ACR. And he was curated and supervised by Peter Nash from Australia, who will also joining us for the question and answer following the treatment section. And then Isaac Cheng from Hong Kong will present the clinical topics that were presented and the highlights from ACR 2025, and he was supervised by Elaine Hasney. And then we will hopefully have some time for panel discussion and Q&A. And really happy that we are having Jeffrey Chow as a PRP with us today, and who will contribute with the patient perspective, which is always really invaluable for us to also hear about these highlights. We hope that you enjoy the program. We will also be really happy to get any further comments, how we could further improve the program for upcoming episodes. And we really want to hear your perspective and get your questions directed to the speakers. So you have the opportunity with the question and answer bottom asking your questions, and we will be directing them to the speakers. And without any further ado, Hannah, I want to invite you to the stage and give the word over to you, because you created the basic science highlights, and it's always a pleasure hearing you speak, and I'm looking forward to it.
Okay, thank you very much, Fabian. Let me just get my IT and screen share sorted. I think you should see my slides now. So thank you very much for the introduction. These are our disclosures, and my other disclosure is that I've got a cold at the moment, so if I don't make sense, that's what I'm going to blame. I'm going to present 5 basic science abstracts today. The first one is named the effects of IL-17A inhibition on enthesial osteoblast and fibroblast dynamics in psoriatic arthritis, insights from the eBio biopsy study, and it was presented by Andreas Ramming from Erlangen in Germany. As everyone in this audience will know, enthesitis is a hallmark of psoriatic arthritis, but studies to date have mostly focused on preclinical and surgical samples. But what this study did was to investigate immune and non-immune compartments in patients with active PSA and active psoriatic arthritis who were treated with an IL-17A inhibitor. So they enrolled patients who were had active psoriatic arthritis, were eligible for systemic treatment, and who also had Doppler ultrasound evidence of synovitis as the lateral epicondyle at the elbow. And they took biopsy from this site at baseline. The patients were treated with secukinumab 300 milligram every 4 weeks for 24 weeks, and then had a repeat biopsy. And they did multiple analyses on these tissues, as well as, of course, careful clinical assessments. So in terms of their results, and for the baseline characteristics, they enrolled 10 patients, and 4 of them were female. They had a moderate disease activity, and their SPARC enthesial score was 4.3. At 6 months, 9 of these 10 patients had responded clinically and also on ultrasound scan, and they met the primary endpoint, which was a greater than 50% reduction of immune cells at the enthesis, and this was met in the 9 responders, but as you can see on the graph, not in the 1 patient who did not respond clinically. So what were the cells they looked at? So to the left in this volcano plot, you've got cells which were higher pre-treatment, and you can see the pro-inflammatory macrophages, you can see IL-17A positive T cells, which of course is no surprise. And moving to after treatment on the right, there were an increase of pro-resolving phenotype cells, in particular the CD200 DKK3 fibroblasts. And I should also mention that they looked at different subtypes of cells which can produce IL-17A, and that there was a reduction in all of those. In terms of the pathway analysis, there was a significant reduction in osteoblast differentiation. So the take home from this one is that enthesial biopsies from patients with psoriatic arthritis are feasible, and also that IL-17A inhibition reduces the number of IL-17 producing cells, reduces osteoblast differentiation, and it increases the pro-resolution stromal changes. The second abstract is from the same group and was presented by Maria Gabriela Raimondo, and titled Skin to Joint Immune Cell Migration and Synovial Reprogramming in Psoriatic Arthritis Onset. You might recognize this title from the annual meeting and trainee symposium, as Gabriela presented at the meeting. And this slide is stolen from her newsletter infographic. So just briefly, the big question here was, does a skin to joint axis exist, i.e. do cells migrate between inflamed skin to joints? And she first studied this in IL-17 overexpression mouse model in something called KD mice. The KD mice causes color change in cells when they are exposed to UV light. So that way she could track migration of a group of myelocytes from inflamed skin to the joint in mice. However, it did not always induce synovitis. She then took some human samples from patients with psoriasis and psoriatic arthritis, and she analyzed skin, synovium, and blood, and did something called mitochondrial DNA sequencing, which can prove that it's the same cell lineage in the different sites, and showed that they were present at both sites. And what you noticed in both mice and human synovium was that in the cases where there was no arthritis, no joint inflammation, there was an increase of the CD200 fibroblasts. And yes, that is the same type of fibroblast that you heard me mention in the first abstract. So the take-home message from this is that there are myeloid precursors which do migrate from the skin to synovium, and that CD200 synovial fibroblasts can prevent them from becoming pro-inflammatory. The next abstract is, I suppose, staying in the mouse world, and was titled Axial Psoriatic Arthritis is Phenocopied in a Humanized Mouse Model, and was presented by Maria de la Luz Garcia Hernandez from the University of Rochester in Christopher Richlin's group. And this same group had previously published a mouse model in an immunodeficient NSG-GM3 mouse, where they found that through injecting these mice with PBMCs and serum from patients with peripheral psoriatic arthritis, they could reproduce the human phenotype in the mouse. And what you can see in the images here is the synovitis in the middle, and also erosion on the right-hand side. So the question and answer in this abstract was, if these mice are injected with PBMCs and serum from patients with axial PSA, can that phenotype be reproduced? And the short answer is yes, it can. And I think you can see this quite nicely with the kyphosis, with the spinal fusion and erosions, and also bone resorption and some tail inflammation and necrosis. When sort of looking a bit closer at the samples, they found that immune cell infiltrates in the dorsal root ganglia with proliferating CD3 cells, and also with the, in particular, CD8 positive, IL-17 TNF alpha positive cells. So the take home from this is a novel mouse model to study axial PSA, because of course we all know that mouse models are full of flaw, but here is a new one. So changing topics slightly with the next abstract, and this was single cell RNA sequencing immune profiling of blood samples from a psoriatic disease clinical trial reveals a CD4 T cell population associated with the response to IL-23 blockade, and it was presented by Catherine Marks from the Brigham and Women's Hospital. So obviously this is one of the hot topic in research interest at the moment, trying to predict response to treatment. And this study analysed samples and patients participating in the MINIMA study, which was investigating the IL-23p19 inhibitor tildrakizumab. And it included 21 patients with psoriasis, 6 patients with psoriatic arthritis, and they all had moderate or severe skin psoriasis. Note to focus on skin here. They collected PBMCs at baseline and 24 weeks, did RNA sequencing, and kind of the usual analysis of single cell sequencing. In terms of response, approximately half of the patients had a PASI improvement by 70% at 6 months, and these patients were compared to those who had less than a 70% improvement. And looking overall at all of the PBMCs in blood, there was no difference between the groups. However, when they looked more specifically at the cells which they thought might be more implicated, namely those expressing the IL-23 receptor, they did find a difference with one cluster increase in the responders and one cluster increased in the non-responders, as you can see on the graph here on the right. And among the response-associated T cells, the gene signature corresponded to pathogenic Th17 cells. So the take-home message from this is that the abundance of a CD4 positive subset in circulation before treatment may predict the clinical response to this particular IL-23p19 inhibitor. But I should highlight that this was in skin, small sample size, so of course verification is needed. Okay. The next, and moving on to my final abstract I'm going to present, was titled Preclinical Characterization of a Novel Bispecific Antibody Targeting IL-23p19, again, and IL-36 receptor for the treatment of autoimmune diseases, and presented by Qian Yin from Jiasu Hengru Pharmaceuticals in China. Apologies for the pronunciation. But first of all, what are bispecific antibodies? So quite simply, they are antibodies with two distinct antigen binding sites. However, depending on their chemistry, they can have quite different actions. And during the ACR meetings, there were a few both non-psoriasis, psoriatic arthritis related talk mentioning the T cell engagers, which I suppose like the CAR T cells are getting borrowed and taken from the oncology field, where one of the antigens will recognize and bind to a cytotoxic cell, bring that into close proximity to a cell expressing a pathogenic marker on the pathogenic cell, thus inducing basically killing of the pathogenic cells. Anyway, and then there are also bispecific antibodies, which, as it says, just identify two different ligands, and that is what this particular compound studied in this abstract did. And IL-23p19, of course, does not need any introduction. The IL-36 and IL-36 receptor, I think, will be more familiar to any dermatologists in the audience, as actually there is a treatment targeting the IL-36 receptor license for generalized pustular psoriasis. But that's an introduction for the rheumatologist as well, who might not have been aware of it. So this was a preclinical study, and to be honest, the reason for including it was to just talk a little bit about the bispecific antibodies. But what they did in vitro, so lab work to show that the targets were binding what they were supposed to bind, and that blocked the downstream pathways that it would be expected. And when they did co-culturing, the antibody, the bispecific antibody blocked it better than the single antibodies. They then took it into a mouse model and found that the bispecific antibodies improved the psoriasis skin phenotype, and it was also safe in monkeys. So, take home from this is that this is a novel bispecific antibody targeting cytokines implicated in psoriatic disease, but obviously far, far, far away from clinic. So that was the end of my presentation, hopefully pretty much on time.
Perfectly well. Thank you so much, Hannah. And it's a pleasure to invite you, Dirk, also on the stage. And every one of you, just, yeah, be very curious and ask your questions. And I will be directing them to the both experts that we have here. To be honest, on the first abstract that you presented, Hannah, I'm not a basic science guy, as you know, but your take-home message was really relevant also for me with my clinical expertise. It is feasible to really do specific biopsies of the anterior site and getting then cells that we can analyze and really giving us a better idea what is going on in the antithesis, which is quite challenging to treat. And therefore, I think this will be really something that we can look forward into the future, that we will having the opportunity to really assess the antithesis side. And from my understanding, I think the results found are quite interesting, but most likely will not be specific to IL-17A, which was assessed in this study. However, to have the opportunity to maybe even have head-to-head studies assessing the different efficacies on the anterior side, I think this is really fascinating and intriguing for the future. But really happy to also, Dirk, hear your perspective on the presented abstracts and yeah, get your perspective.
Yeah, well, I first like to thank Hannah for doing a tremendous job. I think it's not so easy for to making this in a comprehensive way. So I thought you did a great job. As a senior or the oldest guy probably here on the call, it's probably something to be said, and I can't reiterate. It's kind of a lot of work, and you did it really great. So I agree that from a translational angle and like this antigial biopsies is really a really fascinating area. I mean, like a rheumatologist, I think in general we have been too much for a long time on the soft side and feeling and pressuring. But now with the synovial biopsies, the first thing, but now antigial biopsies we thought was impossible is getting there. And I was recently at another meeting that even, let's say, the fibrocartilage can be sampled, right? So it's quite, this will learn us a lot, I think. And it's addressing unmet needs because enthesitis has been notoriously difficult for clinical assessment. That I think as I couldn't agree more. This is like really a breakthrough. The bispecifics, I think, just as a general comment, I think the bispecifics, the challenge of bispecifics is that you anticipate that they are working in a fixed ratio, right, from patient to patient. So you have two targets hitting at once, but that assumes, let's say, that you would have them equally present, right? So and that has been a bit a challenge. So sometimes, that's why sometimes perhaps, let's say, having two mode of actions simultaneously might be better than a bispecific. So a bispecific has that, at least one of the limitations of bispecifics. But I see hand raised, Peter and Jeffrey, yeah.
You're still muted, Peter?
Here we go. Unmute myself. Well, thanks. Excellent presentations. Just two comments. The other biospecifics that we've seen, for example, TNF plus IL-17, they haven't had any additional benefit over one by itself, even when they showed that they were able to block both quite significantly. So the challenge is always to show that the biospecific actually adds clinical relevance to the monotherapy, if you like. And the other thing is fascinating in the enthesis. The group for University of Queensland had showed beautifully that bacterial cell wall from the gut finds its way into the enthesis and acts as an antigen. And I think this study from skin to enthesis and gut to enthesis will really teach us a lot.
Couldn't agree more. Thank you, Peter. Jeff, your hand is up as well. And how can you contribute with the PFP perspective? Really excited to hear your comment.
Well, first, thanks for Hannah for the basic science summary. It's amazing to see all the developments. Just one point I want to highlight. While the anti-cell biopsies for patients with PSA are feasible now, some patients may feel hesitate about the procedure. They may prefer alternative methods like imaging or other non-invasive exams. So therefore, it's important to have a shared decision-making process with the patients regarding the examination options because they may not keen on this kind of type,
Yes, very valid point. But I think it's also important to stress that this was minimally invasive and they were doing ultrasound. and then they were having a very small needle biopsy from the enthesis. And I was also speaking with Andreas, who was mainly guiding the study, and he said that, well, the patient tolerated it quite well, because this was the really futuristic thing about it, because previously we were able to do major surgical biopsies, but with this minimally invasive biopsies, which were tolerated really well by the patients, and they were also redoing them after therapy. So this really shows the patients having the biopsy, having treatment, and we're coming back to get the biopsy again, because it was not that painfully or invasive that they said, well, thanks once, but never again. So I think this really shows us that it is an option, but I do agree with imaging, we can monitor inflammation. However, we were falling short of understanding what was going on in the enthesis, and this is what really makes us so excited about having this as an futuristic diagnostic approach in our setting as well.
Yeah, so maybe if I can add on this. So this method was originally, I think, developed in Erlangen with help from the Italian, and so in Rome, actually, like they made it a little bit more minimally invasive. Both centers actually looked at it, let's say, the patient satisfaction and the willingness to redo this. And for elbows, which was basically the region that they do at the moment, it's like so they can do it. I mean, this actually for me is the main novelty. You can do repeat, right? You are actually convincing a patient at trial to do repeat. So that's very encouraging. And I think we are only at the beginning, I think, of because technologies now, we are matching now technologies with new areas we have never studied, which is really exciting, right? Of course, the downside is, it doesn't really work for Achilles tendon, etc. But, probably, things evolve. But I think it's definitely very fascinating, because it will lead us to a deeper understanding what's the difference between synovitis and enthesitis in immunobiology. Definitely with impact.
And maybe it will help us to understand also better the things that we see by imaging. And so, because we can correlate then the rather deep basic science and molecular basis, what we can then retranslate to imaging, that we understand better and implement better imaging modalities for future follow-up. So maybe this really gives us the opportunity to improve the imaging modalities by our understanding of what is really going on in the enthesis. Peter, your hand is up again, I think. Yes.
Yeah, I love the Chris Richland work, because it's not so much the mouse model, but what is the factor that's transmitted in serum or peripheral blood mononuclear cells that can produce the disease? And if you can isolate what that is and block it, you've got a completely new treatment path. The work with the TRBV9 plus antibody in the AXPAR group, is this antibody driven? Because we've never thought of this group of diseases as anything but auto-inflammatory. And that's the first hint of an antibody. And then you open the whole door to B-cell therapies. So I just wonder what the factor is that is transmitted in serum and in peripheral blood mononuclear cells that can induce this whole phenotype.
I mean, that is, I suppose, really an interesting question. And as you will be aware, when they only transfer the PBMCs, they don't get the phenotype. So there is something in the serum that is required for the transfer. And I suppose we also got with a single cell synovial studies showing actually quite a large number of B cell presence. In the work I did for my PhD, I found immunoglobulin upregulation in skin lesions in psoriatic arthritis, but not in psoriasis. So I'm beginning to think that there is some role for the B cell compartment that so far not recognized in psoriatic arthritis, would be my take on it.
Yeah.
Yep.
So yeah, Peter, I think I asked, I mean, it's always reassuring. I asked exactly the same question to Chris Richard, right? Why do we need a serum, right? Is there complement activation in this model, right? So I think it's still a bit, I mean, it's really interesting, right? So I think, I mean, there's a number of options. IDU induced, either it's some kind of autoantigen and then I mean, if you go back a bit in history, there's this proteoglycan-induced forms of arthritis, which gets like spondylitis. So is this the trick here? Fine, there's a number of things, but I think it's definitely fascinating. My take on this is that more people should do this type of work. More centers should do that, just to, you know, spread the word and actually be more confident that this is a model reproducible, because it would be really interesting, right? I think, yeah. But it's interesting you had exactly the same question that I asked.
I was also wondering in the same direction. I was also asking myself what kind of phenotype of actual PSA, because I mean, this is from the clinical perspective, this is a discussion that we frequently have. What is the actual PSA phenotype? Or was it more actual SPA-like, or was it the typical? So this is also, I would like to know more about the patients from which the serum, the PBMCs were transferred. So I really liked the discussion. I enjoyed your presentation a lot, Hannah. Thank you so much for making this comprehensive and also understandable for clinicians like us and patients like Jeffrey. Thank you so much. Dirk, thank you so much for supporting and mentoring Hannah on this. I like the discussion. However, we need to move on. And as said, we will now go to the treatment, which is always also a real highlight, because we will see what will be able for us to perform in the future. And it's my real pleasure to introduce my friend and colleague, Andre, currently chairing Young GRAPPA, and hearing your presentation that was supported by Peter in the construction on the treatment highlights from ACR 2025. Andre, the stage is yours, and I'm really looking forward to your presentation. Thank you so much.
Hello, everyone, and thank you, Fabian, for the warm introduction. It's really a pleasure to be here as part of the GRAPPA ACR 2025 highlights. So I'll be presenting, as you said, the treatment highlights session, which was co-developed with Professor Peter Nash from Australia. These are our conflicts of interest, which have not influenced the presentation nor the selection of abstracts. Let's begin with sonelokimab. So sonelokimab is a novel IL-17A and F inhibitor, meaning a mechanism similar to bimekizumab, but with a distinct molecular design. In that sense, sonelokimab is a nanobody, so a very small single-domain antibody fragment, which, because of its smaller size, could theoretically achieve better tissue penetration and improved local efficacy. The central question is whether this smaller molecular profile will indeed translate into better clinical benefits than other available drugs. The ARGO trial, for those who don't remember, was a phase 2b randomized placebo-controlled study evaluating multiple doses of sonelokimab in patients with active PSA. They included 207 patients with active disease, at least 3 swollen joints and tender joints, and either active psoriasis or history of. They compared different dosing schedules, including induction versus no induction, and an adalimumab reference arm, with a primary endpoint of ACR 50 at week 12. Here we can see that the ARGO trial met its primary endpoint, and this was presented in another conference. So both sonelokimab 60 and 100 achieved significantly higher ACR 50 responses compared to placebo at week 12, in numbers ranging from 46 to 47% compared to 20% with placebo, and that these results were consistent whether or not an induction phase was used, suggesting that even without induction, efficacy was still present. What was new at ACR 2025 was the presentation of exploratory data isolated to patients that were bio-naive. So in this population, they also assessed for a more stringent composite outcome, meaning the combination of ACR 70 plus PASI 100, which was met by up to 48% of patients at the 120 milligram dosing. Based on those promising results, They also presented 2 large phase 3 trials, ACR 1 and 2, which are now underway. These trials directly compare the 2 most effective regimens from ARGO versus placebo, with the primary endpoint of ACR 50 at week 16, and we also have a risankizumab reference arm in ACR 2. So, in summary, sonelokimab stands out as a next-generation dual IL-17A and F inhibitor using nanobody technology, with strong efficacy across PSA domains, including a very stringent combination of ACR 70 and PASI 100, with a safety profile similar to other IL-17 blockers. And now we have the ongoing phase 3 trials to confirm this data. Next, let's move to ORCA-002, another IL-17A and F inhibitor, but this time designed with an extended half-life by Oruka Therapeutics. So roughly a year ago, we had the presentation about ORCA-001, which was an extended half-life IL-23 inhibitor. And now they presented the ORCA-002, which is the extended half-life IL-17A and F inhibitor. So normally these antibodies, they are taken up by cells via FcRn receptor and degraded in their lysosomes. In this drug, they modified the Fc portion, the specific sequence YTE, which makes the antibody resistant to degradation in lysosomes, resulting in its release back into the circulation. So by enhancing this FcRn-mediated recycling, this modification slows drug catabolism and may lead to higher systemic concentration for longer periods. Structurally, ORCA-002 binds to similar epitopes as bimekizumab, as shown here in the cryo-EM comparison, where the blue and red areas pretty much overlap. So, in short, previous slide and this slide, ORCA-002 is a proof of concept molecule with the same mechanistic class as bimekizumab, but with a pharmacokinetic twist to last longer. In cell-based assays, ORCA-002 performed equivalent to bimekizumab. You can see that the inhibition of IL-17A and F mediated IL-6 secretion or NF-kappa beta activation curves are virtually superimposed. So in terms of biologic potency, ORCA-002 would be similar to bimekizumab in that sense. But the difference then emerges regarding the pharmacokinetics. So in non-human primate studies, to highlight that these are very initial studies, the half-life of ORCA-002 was around 31 to 32 days, compared to 9-10 days for bimekizumab. So roughly a threefold increase. When they modeled this increased half-life in humans, they predicted exposure curves suggesting that ORCA-002 could potentially be dosed every 4 to 6 months, depending on the exact half-life they will achieve in humans, since YTE modifications usually extend the half-life in 2 to 4 times. So in summary, ORCA-002 is a next-generation IL-17A and F inhibitor with pharmacology performance similar to bimekizumab, but with an engineered Fc region that may triple its half-life, which could open door to quarterly or even semi-annual dosing. But as I said, the molecule is still in very early phase development and further studies are much required. Now moving to icotrokinra, this is a completely different concept. So ICO, for simplicity, is an oral IL-23 receptor inhibitor, so a first-in-class target peptide that specifically blocks IL-23 receptor signaling, doing a similar effect to biologics, but as an oral formulation. The ICONIC LEAD phase 3 program evaluated ICO in adults and adolescents with moderate to severe plaque psoriasis, and it met its primary outcome at week 16, with 65% of patients achieving IGA 0 or 1 compared to 8% in placebo, and PASI 90 responses in 50% versus 4%. Here is the study design of ICONIC LEAD. It included over 680 patients, mostly adults, but also a dedicated adolescent cohort. Eligibility required a PASI more than 12 and IGA more than 3, and ICO was given orally once daily for 16 weeks, followed by an extension of 24 weeks. The overall data had already been presented, and what was different at ACR 2025 was Joe Merola presenting the data specific to adolescents, where he showed that by week 16, 84% of adolescents on ICO achieved IGA 0/1, and over 70% achieved a PASI 90, with these improvements being sustained or even increasing through week 24, where PASI 90 was achieved by 89% of patients. This slide shows the trajectory of those responses over time. So we can see rapid and steady separation from placebo as early as week 4 and progressive improvement through week 24 for all the outcomes that were tested, with a PASI 100 of 63 at the end of this follow-up. So to summarize, ICO is the first oral peptide-based IL-23 receptor inhibitor. Across the ICONIC LEAD phase 3 trials, it showed a rapid, robust, and sustained skin response with similar safety profile to other IL-23 biological DMARDs. Now we have the results specific to adolescents, which were consistent with the results found in adults, and the phase 3 studies are ongoing in psoriasis and in PSA. Now moving on to dual therapy. In the recent years, to introduce this concept, several small case series have emerged, presenting their isolated findings about the use of a combination of two biologics or target synthetic DMARDs in various immune-mediated diseases. This study from Madrid, for example, looked at 15 patients treated with dual therapy for various rheumatic conditions, mostly RA and SPAS. The authors reported good disease control, better glucocorticoid tapering, and an overall acceptable safety profile. However, since a minority of patients in that series had PSA, I decided to focus more on our cohort from Toronto, which focused specifically in psoriatic arthritis patients. So the rationale in our cohort to do the combination was pretty much down to earth and real world practice. The fact that many patients do not achieve sustained remission with monotherapy, so maybe combining complementary mechanisms of action would facilitate achieving this sustained remission. In the cohort, we included PSA patients that fulfilled the CASPAR criteria between 2015 and 2024 and followed them prospectively. From 2,000 patients, we found 24 patients using the combination of interest, which would be a combination of a biological DMARD with a target synthetic DMARD, meaning specifically a TYK2 inhibitor or a JAK inhibitor. Disease activity was assessed at baseline 3 to 6 months and thereafter every 6 to 12 months, and these patients are still being followed. This table shows the diversity of combinations used in clinical practice. I know that the letters are small, but it's just to really give an idea that this was really a real world and we used multiple combinations. The most frequent were IL-17 or IL-23 inhibitors paired with TYK2 or JAK inhibitors. Overall, median therapy duration was about 418 days, but some combinations were maintained for over 2,000 days, demonstrating some feasibility over time. Here we can see the individual trajectories for clinical outcomes. So across most patients, tender and swollen joint counts, DAPSA and PAS scores substantially improved in the first follow-up and were sustained over time. The patient skin and pain VAS also improved, but not as much as the objective metrics. Regarding safety, the overall tolerability was acceptable. The most common combinations, as I mentioned, IL-17 or 23 plus TYK or JAK, were maintained for several months without serious infections or unexpected adverse events, suggesting that while caution is needed, this dual target therapy may be viable in selected patients. So really, as a take home, we now have preliminary data indicating a favorable safety profile for dual target therapy, combining biologics with small molecules. In addition, we observed consistent short-term improvements across musculoskeletal and skin domains that need to be further validated in RCTs. To finalize, I'm going to be talking about one strategy trial because we know that with our current efforts, most patients are not achieving sustained remission and that we still lack individualized treatment strategies. So this study, Monitor PSA, presented a real-world pragmatic treat-target implementation across UK rheumatology centers trying to emulate the TYCOPA study design. Here we have the baseline profile from 300 recruited patients. 234 were analyzed in this specific protocol. This Sankey diagram nicely illustrates treatment evolution. We can see most patients starting with methotrexate in yellow monotherapy, followed by escalation to CS-DMARD combinations or to biological DMARDs here in green. By week 48, nearly half continued on methotrexate or other DMARD alone, suggesting that disease control can be achieved with these medications. At weeks 24 and 48, about 1/3, half of patients achieved PASA's good or moderate response, comparable to TYCOPA. And even when looking at DAPSA and MDA, the numbers were good, roughly 40 to 45% for DAPSA and 50 to 55% for MDA remission. So the take home is really that we can implement a treat target approach in real life, similar to what was done in TYCOPA, suggesting that we should try to be more precise and individualized in our strategies. So to wrap up, we talked about sonelokimab, exploring dual IL-17A and F nanobody mechanisms, followed by ORCA-002, which is another IL-17A and F modified to have a longer half-life. Then we continued with ICO, the first oral IL-23 receptor inhibitor, followed by dual target therapy and strategy trials. There was much more to talk about today, but due to time restraints, we had to leave some of it out of the presentation, like the positive results for izokibep and deucravacitinib at 52 weeks, and new insights into GLP-1 agonists and dietary interventions. That's all for today, and thank you very much for your time and attention.
Yes, thank you, Andre. Thank you so much for presenting this in a very comprehensive way. All the highlights that were presented, you were mentioning some others that we should look into. And thank you, Peter, for supporting and selecting the relevant abstracts. I really liked almost everything that you presented a lot. And these were also the highlights that I noted down. as you know, I do have a very strong heart for dual therapies, combination therapies, because when looking at treatment effects, and we just see that roughly 30 to 40% of the patients are not getting the treatment effect that we are hoping for when we are doing monotherapies. I think it's just really logical, and this is something that we also do in our clinical practice, because we are cycling through the different monotherapies that we have available, and at some point we are ending up in needing some new approaches, and then we are also doing some dual therapies. And I think really that having some evidence on which therapies are safe and effective are really valuable for all of us and for the community. And there's also just recently started a EULA Points to Consider initiative, which will be then formalizing the way in which patients overall, this is not PSA specific, but IMiD specific, how and in which patients and which combinations could be done. So I think really this is a hot topic and an ongoing field that we can look forward. And then also having seen the sonelokimab data that are now going to the phase 3, I think this is something that hopefully will be something that we can discuss in the next meetings. And the DOICRA data that you have not presented is, for one reason, I think really worth mentioning, because we hope that we get the approval by FDA and EMA rather soon, and then be able to use DOICRA not only for PSA, which is already approved, but also for PSA patients in the nearer future. And I hope that this will broaden our clinical armamentarium of treating PSA patients soon. Peter, I see your hand up.
I just want to congratulate Andre for a great job and just make a couple of comments. There's now 7 IL-17s in development. How many do we need, and how they're going to stand out one above the other? Because even though sonelokimab is an A and F, if you look at ACR 50, it's about the 40% mark, a little bit higher. So is it just going to be another 60-40-20 kind of response and just give us one other drug, but no huge advantage? I threw izokibep in there because that's another nanobody, but it gave very similar results, and it may not be developed any further because it didn't stand out as anything to be gained. So that was interesting. I love the fact that they're using active comparators, whether it's adalimumab or risankizumab. I think we should really work hard on getting rid of placebo trials, except in the most important registration studies. The ORCA stuff's very interesting. If you think more about the side effects of a 17, for example, inducing IBD and then hanging around for 6 months might be difficult. They're also developing a 6-month IL-23, and that I think would have a much cleaner kind of safety profile. So I think there's the upside and the downside of having 2 injections a year. That's something that we have to think about. I threw DUCRA in there for discussion because where's it going to fit in the treatment algorithm? Where are we going to place it? Are we going to use it? Like in our country, we have to use 2, if you like, conventional synthetics before we get to an advanced treatment. One's methotrexate and the other 2 don't have very good evidence. Are we going to put apremilast and DUCRA in as a pre-biologic kind of place for it? Even in Australia, the GPs are allowed to prescribe apremilast and deucravacitinib under supervision. So that's how far that has gone. ICO is very interesting, but it's an oral peptide with very poor bioavailability, and you have to take it first thing in the morning, half an hour to an hour before you eat a meal. It's like the old bisphosphonates were that we were used to using. But I think it's potent enough to have very good efficacy. So that looks interesting. And I think the combination is vitally important, especially as Fabian, you're defining the separation of treatment refractory from complex to manage. And maybe if we can predict the treatment refractory, we might start with a combination and then reduce to a maintenance therapy over time and have better outcomes. And I think the strategy study that mimics Tacopa has to tell us what the downside were, as Tacopa did, that escalating therapy led to a tripling of serious adverse events. So it's the safety side of treating to target that needs to be filled in. And also, unusually, Tacopa, even though at their time they only had TNFs and nothing else, they had no imaging benefit over time. So they're the two things that I'd love to see from those strategy trials to try and fill in that side of the equation. But lots of interesting things. And I again congratulate Andre for his fantastic work.
Thank you so much, Peter, for your insights. And we have some congrats from the audience, and Ade is also contributing and saying that Peter is a bit too pessimistic and that we should be thankful for new opportunities. And I think this is something when we are looking into the TNF spectrum, that sometimes it's really valuable to have more TNFs available, because we can cycle through. If we have a secondary loss of response, then having another TNF in the armamentarium is really valuable currently, and therefore I would also praise having multiple IL-17As in the future or dual inhibition. Elaine, you have your hand up. Really thankful that you will contribute.
Thank you. And Andre, that was wonderful. You covered a lot of drugs in a very short period of time. So I am actually excited that there are a lot of different and sometimes even more in the same class. But I share, just wanted to echo Peter's remark about really getting away from placebo trials, because I think it's getting harder for us as rheumatologists to recruit for these if we don't have active comparators. So I think there's just a lot of advantages that we should see. I do want to say that in the GI literature, they have combining biologics now a lot more than we have, and perhaps we should learn from them. They seem to be a little bit more aggressive with the combination therapy, so that would be an area of interest that we could share. And then I also wanted to remark that, we're really talking about the, sort of these active psoriatic arthritis, the more typical peripheral arthritis. But as we know, there's a lot of subtypes that we have a lot of trouble treating. So one of the things I'm excited about with these new treatments is that, could they be separated or stratified by the different phenotypes that we struggle with in clinic. So I think that's important. And then thirdly, I think really it would be great if we understand more of the safety issues, because I think that's where things are going to stratify a bit. So, Peter had mentioned the combination therapy or treatment strategies where safety is, but even in the regular, IL-17s, what distinguishes them safety-wise, I think is going to be really important for us.
Yes, thank you, Elaine. Really agree. And Andre, you also have your hand up, and you can also go back to the comments before.
Yeah, well, first, thank you for everyone that said congratulations. I'm really happy you enjoyed the presentation. It's hard to put so much information tightly packed in a few minutes. I agree with pretty much everything that was said, although I'm a little bit more optimistic, as Ade mentioned. But I understand, especially the safety concern with a very long half-life. Like every 6 months, if you have an issue there, then it's pretty problematic. But the area that it's really gaining my attention is really the strategy trials, because we should be learning more about how to individualize our treatments. And in the past 2 years or so, we had presentation of several trials, both at EULAR and ACR, showing that sometimes, most of the time, starting with a biologic first thing didn't change much. But if starting with that biologic in a very poor prognostic population, it did add benefit. So are these small things that really tailor our treatment decisions? I think that's where we should be mainly focusing right now. And dual therapy for me is nothing but also a strategy trial. Be that for a refractory patient, there is treatment refractory and with confirmed objective inflammation, or starting head-on with a dual therapy combination and then going back to monotherapy for sustaining that response. So I think those are the types of trials that are really going to be improving our remission outcomes.
Yes, thank you. I do agree a lot. And I think also sequential therapies, that we could start with something heavy and then maybe just interchanging. I think this is a topic that we should also explore in a PSA. And I see Dirk has his hand up, and I would like to also, Annie, you can help us to get Arti on stage as well. But Dirk, you're first.
Yeah. So two small things. I think this was really wonderful. I liked also the remark from Peter on the long half-life and the issues with that. So I think the way we probably should think about this is we probably need something for the initial phase when you get exposed to a new mode of action, something with a relatively short half-life. We never thought about it, and then you want to have a stable, a stable signal that you would have. That would be nice as a rheumatologist to have. And then the additional thing I think I would like to say is that perhaps you're not aware, but let's say the nanobot, this is the Belgian, it's a bit like Belgian chocolate, right? It was invented in Belgium in the Institute VIB several years. It's really interesting because it was actually a mistake of a student that actually swapped some serum samples for him. And that actually how it was discovered that single chain antibodies come in camelids. That's actually how the discovery was made. It's really Belgian inventive. It's just to know you and realize it, how this evolved. You see, I'm not chauvinistic, but there's one of the few things I'm proud of, that being a Belgian.
Perfect. Thanks for this insight. Is it possible that Arti can also verbalize his comment? Annie, can you help us with that? Arti, are you there? So I think not at the moment. And in the matter of time, I think, oh no, there he is. Arti, pleasure that you're joining.
Hey, can you hear me? Yeah,
Yes,
thank you. That was a great session. Thank you, guys. I think one a point of discussion and just touched upon is that the difference. Some of these molecules may have a different distribution, pharmacodynamic. You mentioned the solanocimab, but also the Icotra, and we may see either benefits from that or we might see downsides from that. We're used to seeing what we have with our macromolecules, but it is possible that, for example, if the Icotra got into the ligaments and entheses at a greater concentration, maybe it would be more effective. But anytime you say something is better, the flip side of that is there may be other toxicities. And if you had as Peter said, a very long-lasting IL-17, and if you had one that had better penetration, maybe it might be good for the bowel or bad for the bowel. It's really going to be fascinating. But great job, everybody.
So I think we can summarize: the future is bright, and we can really look forward what will be presented at the next conferences. And in the matter of time, I again really enjoyed the vibrant discussion with the whole faculty. But I would like to hear also about the clinical topics. And Isaac, you prepared the clinical topics with the support of Elaine, and really looking forward to hear your presentation as the cherry on the cake.
Hello, everybody. Good evening or good afternoon. And here is midnight in Hong Kong. So can you see my slides? Yeah, so I will move on to talk about the clinical topics. So I've selected 3 abstracts to be presented in this section, and thank you for inviting me to share with all of you. So here's our disclosures. So the first abstract is about the 6-stage gadolinium PET-CT, which reveals the increased fibroblast activation in the synovial and epithelial tissues in psoriasis patients with arthralgia, and that could predict the development of PSA. And this studies has been conducted by the Elegant group. And so to begin with, so the background is this is contrast PET-CT, which highlights the fibroblast activation protein and show the abnormal fibroblast activation in the patients. So we can see from this diagram here, we can see the signal they detected for the abnormal fibroblast activation. So in this particular study, what they are doing is they recruited 45 patients with psoriasis and arthralgia without definite diagnosis of psoriatic arthritis, and they performed the ultrasound and also the PET-CT at baseline and follow up them for every 3 monthly, and then the endpoint is a PSA diagnosis. And the outcome was to looking for the clinical and disease-related factors associated with the increased peptide uptake in the psoriasis patients, and also the association between the synovial and visual peptide uptake and the subclinical ultrasound changes, as well as the association between increased peptide uptake and the risk of developing PSA. So here comes the result. So in this 45 patients, 37 of them actually had positive peptide, and then when we are looking at demographics, the patients are in the age of 50s, with more than half of them are male, and when they have also have moderate disease activity, and when we compare those with positive peptide results with those with negative results, we see a higher BMI and also a higher CLP in those with the positive peptide results. And looking into the peptide uptake, we can see that the most peptide uptake are frequently detected in the mechanically stretched sites in the large joints like the shoulder joints, the greater trochanter, and the knee. And indeed, about 8% of the synovial and visual sites displays increased peptide uptake. And when they are looking into the ultrasound findings, they find that 6.2% of the synovial site has low-grade synovial hyperplasia, and also about 10% of them have hypoechogenicity and calcification in the epiphyseal sites here. And when they looking into the association between the peptide joint index with the ultrasound finding, they find increased rates of having a higher joint index if there are presence of synovial hyperplasia in the joints, as well as having paradoxal signal from the emphasis. So, and more importantly, what they find is when they are looking into the follow-up period, they have a mean follow-up period of 42 weeks. And then when they are looking into those who had positive peptide findings, 51% of them actually developed into PSA, versus only 1 out of 8 of those without positive findings of the peptide test that developed PSA. So they have a 7-fold higher risk of PSA progression in those with peptide test positive. So in this, they further look into the PET joint index and also the signal uptake, and they find that the joint index is significantly higher in those in the peptide and those who develop PSA, as well as the total uptake and also the joint uptake. So the conclusion is the fibroblast activation detected by the peptide PET-CT is actually a frequent findings in the psoriasis patients with arthralgia, and this uptake at the synovial and visual sites correlates with a higher BMI and a higher death-stranded CLP. And this uptake also correlates with the findings on the ultrasound changes. And the presence of peptide uptake correlates with a 7-fold higher risk of PSA, while the absence of the peptide uptake at baseline is highly predictive of non-progression to PSA. So why is this study important? So we think that this study actually strengthens the pathogenesis hypothesis that fibroblast activation is an initial step on the road to develop PSA, and this may also represent a valuable tool for the risk stratification of those psoriasis patients, and it might be able to help us to identify those who are at much higher risk, and we might follow up them more intensively, or even implement some interventional strategy to prevent the development, or let's give some insights for our next study design. So moving on, I will move on to the second abstract, and this is actually, I think that might be one abstract Andrea wants to highlight as well. So this topic is about the dietary intervention in PSA, and this is RCT from the Toronto group. So this is called a diet intervention in PSA study, and this is multi-center RCT to compare the effectiveness of 2 personalized dietary intervention in improving clinical outcomes in patients with active PSA compared to control. So here comes the study design. So they include PSA patients with obesity with BMI 25 to 40 with moderate disease activity or TAPSA over 10. But then they should have stable therapy throughout the study period, and it is a 24-week study, and they should not be on glucocorticoid or GLP-1 medications. And these patients were randomized into either the low-calorie intake group or the Mediterranean diet group or the control group. And the primary outcome is the depth change in the week 12, and they also look into the depth change at week 24. So throughout the period, the patients were educated about the nutritional intervention, and they have a consultation with the dietitian, and they also have daily reminders to track how their diet is going on, and the patient report about their quality of life, the pain score, exercise, and dietary consumption, and they also have the rheumatologist consultation. And as comes the results, so the age of this cohort are also in their 50s, and actually the baseline profile are comparable between these three groups. And here comes the results of the primary outcome. So at we look, first of all, we look at the weight changes. So at week 12 here, we can see actually all of the three groups had significant reduction in the weight. But then it is modest changes with about 1 to 2.5 kilograms. But then there were no significant difference in the weight loss between the three treatment arms. And this was also observed similarly in week 24 about the weight changes. Okay, how about the depth of change? So at week 12 here, we can see a significant reduction in depth in the low-calorie diet group and also the control group. And then moving on to week 24, all groups shows improvement in the depth, and there were no significant difference between the three allocated treatment groups. And they further look into what's the relationship between the weight loss and also the change in depth. So, for example, we can look at the figure 3A in the left panel here, and we can see that if they have a higher reduction in the weight here, they actually correspond to a greater drop in the depth, a better improvement in depth. We can see this similar trend and also for the tender joint pain, the PSA or the fatigue score here. So weight loss is magnitude is more significantly associated with the improvement in this clinical outcome, which are independent of the treatment groups. And then when we are looking into the second row here, I'm sorry for the small figures, let me try to enlarge it. Okay, it is larger here now. So for example, we look at figure 3F here. So for those patients who have over 5% of weight reduction in this three group, we can see a greater reduction in the change in depth here when we compare to those with less than 5% of weight reduction or no reduction. And then we also see such trend in terms of the tender joints and also the pain score changes and the PSAID, the quality of life changes, and also the fatigue. So there's a clear trend showing about the weight loss and the improvement of the these clinical outcomes. So to conclude, both the personalized dietary intervention and standard dietary advice led to modest weight loss and improvement in PSA disease activity. And why this is important? Because it was demonstrated that the degree of the weight loss rather than a specific dietary strategy was the primary determinant of clinical benefits. And hopefully we can address our patients who always ask us, oh, doctors, what shall I eat to improve, or what shall I not eat to avoid something? And this might give us some insights. And finally, I move on to the third topic. It's about the GLP-1 receptor and agonist, which was also mentioned by Andrea. And so this is from retrospective study. And this is talking about the mortality and the MACE event with the GLP-1 in PSA. So, reaching from the previous abstract, we know that obesity is an important component in the complex mosaic of autoimmunity, and this study explored the scope of GLP-1 beyond the weight loss. And so actually this was an observational and retrospective study, and the Trinetics database was utilized, and they compared two cohorts. The first one is the PSA patients with GLP-1 RA use, and the second cohort is those without the GLP-1 RA use. And what's so special about this study was they actually used the propensity score matching to match the age, the sex, race, the diagnosis, and the medication. So this is a retrospective study, but then they try to make the two cohorts as comparable as they could to eliminate potential bias. So in this retrospective study, they define an index weight to start with, which is the simultaneous appearance of PSA and also the GLP-1 RA use during this analysis. And here's the outcome of interest was amazing. This here is ischemic heart disease, cerebrovascular disease, acute myocardial infarction, cerebral infarction, and heart failure. And they excluded patients with MACE before the index range occur. So here's sorry for the busy table, but then we can look at the yellow column here. So the left column is from that database. They actually have many patients, but then after the propensity score matching, they still have 3,000 something patients, which is quite a large sample size here. So they have the age in the 50s, and then the female having about 70%, and then the majority were white people, and then they also match with the cardiovascular disease and obesity rate, and also the use of various medication. And here comes the major results. So they have the propensities for matching here. We look at this column here. So after matching the patients, the risk ratio for having ischemic heart disease was 0.7 here. In those, so that means that for those who are having the use of GLP-1 RAs, they have reduced risk of the ischemic heart disease. And we also see a similar trend 0.6 for cerebral vascular disease, and also for AMI it's 0.5, and etc. here. So to conclusion from this study was the PSA patients on the GLP-1 RA have a lower risk of developing MACE and have a reduced mortality compared to PSA patients not on the GLP-1 RAs. And this is an important study because it uses the post-parenthesis for matching for adjusting the bias between the two groups, and it addresses the limitations from the previous study. And the GLP-1 RAs may be a promising adjunct therapy in the management of patients with inflammatory arthritis. And so these are the three abstracts I've selected, and thank you very much.
Yes, thank you so much, Isaac. Again, a very great presentation summarizing all the highlights that were presented at ACR. And thank you also, Elaine, for supervising and selecting these abstracts together. We heard also on the effect of GLP-1. I think it's not really surprising that they also have a beneficial effect on the cardiovascular disease in PSA patients, because why should PSA patients be so different to the general population? However, I think really looking also how they can support treatment efficacy in PSA patients by reducing weight and the potential immunological added value, I think this is something that will be really exciting for the near future. And also maybe having them as monotherapy for PSA by just reducing weight could be an interesting option. And I know that there is already really studies ongoing with the added value combination of GLP-1 agonists together with biologics, and maybe your perspective on this, guys, in the group.
Yeah, I just wanted to really thank Isaac. I think the hardest part was to pick just 3 for this session. There were so many exciting things that happened in psoriatic diseases at ACR. But I just want to comment on the imaging study. I think that, this group has made me feel a little bit more comfortable about endothelial biopsy. So maybe having imaging can guide other places that we could be doing this biopsy as well to get us more information. So I do think this high-tech imaging is really exciting. Second, I want to talk a little bit about diet, and then I'll wrap up to Fabian, your comment on GLP-1s. In terms of the diet, I think, many of us are not going to be against telling people to eat better and lose weight. But I always wonder how to get people to adhere to these in the long term, like past the 5 weeks, 6 weeks, that they're doing. I think that's the real challenge. And you wonder in these studies, and I'm sure this group will elaborate when the paper comes out, about adherence and also how they can help us keep our patients, in the long term. Because you wonder if you're just meeting people, they become more, more motivated to watch their diet, right? So it's really the long term when they're off the study. So that's important to know. And then lastly, I think all of us are so excited about GLP-1. We're seeing all the non-weight effects as well. I'm sure all of us are seeing this. The question, I think, to the group is, do you think we should really lower our threshold to start these medications? Not wait for them to get diabetes and for them to be really overweight before, we are thinking about them. And, is it our role as rheumatology to really, help these patients get on these drugs sooner?
And yes, I can say for me, my personal opinion is a clear yes. At least here in Germany, it's not that easy to get patients on the medications by the payers. And I think this is something which really differs from country to country, the costs, but also the entrance level, how we can get them on. And I think here more data on the efficacy, also on the PSA activity, will really support us in doing so. And I think this is therefore it's really utterly needed. And I'm a huge fan of the DIPSA study and just nutritional interventions in general, because I think from my understanding also from the data on gut microbiota that I've seen and how I would interpret them, I think that nutritional aspects and intervention are such a strong tool that we don't fully understand yet, but that will hopefully help us really to treat differently or shape the disease course in the future when we're understanding it better. And I cannot agree more on the long-term run comment that you made. And Jeffrey, I think this is a very important perspective also from the PRP perspective. So happy to hear your comment on this. You're still muted. Sorry, Jeff. Yeah.
Thank you, Isaac, for the clinical topic highlights and Elaine's comment. Early detection and proactive treatment are critical for patients with PSA. I'm interested in the GAFAPI study. I want to know, currently, are there any approved medication or treatments that target the fibroblast activation for patients at high risk of developing PSA? Is there any?
No, they're not. Clear answer, clear and easy answer.
Then we need to try this direction then.
And I have to also bridge to Elaine's comment on this, because to my understanding, I mean, these images, they are really incredible looking, and also combining them with clinical data is fascinating. However, I would like to see the combination of the biopsy studies together with the FAPI-PET to really understand better what the molecular imaging is showing us, because I'm not 100% sure that we are really seeing active disease, or it could also be remodeling that we are observing here. And I think because they're coming both from the same group from Erlangen, I would love to see the biopsy studies and combining them with the FAPI-PET data, because I think this would really help us to understand better what we are assessing here. Peter, I see your hand up.
Yeah, just to comment for Jeffrey, there is Merck's developing a drug called tusilokibart, which blocks inflammation and fibrosis, and might be helpful in interstitial lung disease, this area as well, chronic active hepatitis, who knows? But so there is one that I'm aware of that's trying to block the development of fibrosis as well as inflammation. So watch this space.
But this is quite preliminary, and they will also address this in PSA patients and phase 2 studies coming up. So I think this is something in the nearer future that we can hope for results here. Thank you, Peter. Yes, I don't see any comments from the audience at the moment, but this is also something, I mean, a FAPI-PET, this is quite elaborated and also quite expensive at the moment. So most likely not something that we are able to use tomorrow in our clinical practice. However, advising patients about weight loss and a healthy nutritional aspect, I think this is something that we are already doing, and having better data to really be as convincing as possible can really change the way that we are able to convince patients, not just doing it for their own sake, but really having data showing that this really helps also in addressing the disease activity. Okay, everyone. So I really enjoyed all the presentations. Thank you again for 3 brilliant presentations. Thank you a lot, Hannah. Andre, thank you so much, and Isaac, you as well. But also thanking the seniors that were supporting, mentoring. So thank you to Dirk, thank you to Peter, and thank you to Elaine. And Jeff, it was really helpful for us to also have you here with your patient perspective. And as always, I want to really thank Annie and GRAPPA administration, because what they are doing behind the scenes, this is just incredible. And thank you so much. And because we just had one comment in the Q&A section as well, someone had to drop off earlier and was asking for the slides, but you don't need to worry, because the whole session is recorded and will be made available afterwards. So if you haven't had the chance to watch the whole webinar, don't worry at all. You can rewatch it live. And if you were able, you can spread the word, because this will be available on demand also later on. And with this, I just wanted to again send out the warmest wishes to Lourdes, who couldn't be here with us today. And next year, in 2026, we will start this again with the virtual Congress highlights, and we will be starting with AAD. Then we are going to EULA, then EADV, and then ACR again. And we're really looking forward. And as said, we would also be very thankful if you would provide any comments how we could improve the content, that it is more fit to what you think is the best that you can use in your clinical practice. And with this, I think we are here on the, almost on time. Thank you so much for your participation and your interest. And it was a real pleasure being able to be here and listening to the brilliant presentations. Thank you so much.
Thank you.
Goodbye.
Goodbye.